All right. Very sorry for the delay this morning. A little bit of a traffic issue. Okay, why don't we get going? Okay, first question today. This is a couple of different topics today, but mostly pacemakers. And I'm going to apologize. I got late yesterday. I was asked to have a meeting at 7:30, so we're going to break a little early today. So I apologize in advance. All right. Question is, this is actually a scout film from a CT scan, which is why it looks so strange. And the question is, where are the pacemaker leads, and are these uni or bipolar leads? Obviously, they are epicardial leads, and we'll start with this lead over here on the patient's right side, and then the left-sided lead. So why don't we ask Dr. Zawani what he thinks?
Right. Good morning, Dr. Bass. Yeah. So let's see. So I think the lead to the one on the right is yes, that one is in the RA.
Mm-hmm.
Okay, and then let's see. The second one is for the RV.
That's correct. That's correct. It's hard to tell, right? It could be on the rightward border of the LV, but it looks most likely to be on the LV. And are these, do you think these are unipolar or bipolar leads, Tarek?
Let's see.
What's the difference in terms of unipolar versus bipolar, in terms of what's attached to the heart?
So I think a unipolar has a single conductor, right? And then kind of like the bipolar has one that goes in the has two conductors, one in the distal electrode.
Yeah,
and
from the distal to the proximal electrode.
Proximal.
Right.
Yes.
So are there two conductors on each lead, or one in this case?
I think it's one.
Right. These are unipolar leads.
Yeah.
So there's a unipolar atrial and unipolar ventricular lead. So typically surgeons, we would, in a perfect world, we would prefer surgeons to place bipolar leads everywhere. Because so remember that in a unipolar lead, the electrons are coming out of the lead that's attached to the heart, and they're traveling to the actual pacemaker itself is the other pole. So the pacing, remember, all pacing is to be a circuit, so there needs to be a cathode and an anode. So in this case, the lead and the device are the cathode and anode versus a bipolar lead where they're both integrated into the same lead. So in a sense, it's a little bit of a misnomer to call a unipolar lead unipolar, because there are in fact two poles. It's just that there's only one pole that's touching the heart, or is in the heart in this case. So the reason that we would prefer, what would be the advantages of a bipolar lead versus a unipolar lead in any patient, do you think?
Sorry, I was muted. So so bipolar, you would have like a much higher surface of like of stimulation or contact?
Contact usually is about the same, I would say. The main issue is sensing. So the sensing can often be, you often get a lot of far field electrical activity in a unipolar lead versus a bipolar. Remember, if the if you imagine that this, instead of being a unipolar, is bipolar, and there are two pods here, then you're sensing directly and only from the area of the ventricle where it's attached. Whereas in this case, you're sort of sensing between these two, cathode and anode. And so sometimes non-cardiac electrical activity can be missensed by the device as activity, and it could cause inappropriate sensing and stopping of pacing. This is not usually as big a deal on the ventricular lead, but on the atrial lead, oftentimes there'll be a lot of far field ventricular electrical activity that can be seen on that lead, and sensing may occasionally be a problem. In general, these work very well. The most important reason that we like bipolar leads for epicardial leads is that a number of studies have shown that, as a general rule, bipolar epicardial leads have a greater longevity than unipolar leads. There's a lot of studies that came out of Michigan in the 90s that showed that their longevity of leads was quite superior with bipolar versus unipolar leads. There's probably one major reason, which is simply when a patient has a bipolar lead, if one of the conductors were to break, you could always reprogram the device as unipolar. So in other words, you have sort of two chances with with a bipolar lead, as long as the cable from the pods to the device is intact. So as a general rule, we would prefer a bipolar lead because, for example, a lot of pacemakers have as an emergency feature that if the device detects an impedance rise that is sudden and large, it will automatically convert to unipolar modality. And so that's a nice feature as a safety feature, both from the perspective of longevity of the lead, but also a safety concern. If a patient were to break one of the attachments to the heart, you would automatically convert to unipolar. And sometimes that's how we know there's been a problem in the, is seeing that it's unipolar, as soon as you interrogate the device. In the present era, most devices will give you an immediate warning, but sometimes you actually just notice that you're unipolar, but you didn't program the patient unipolar. And then when you do bipolar check, you see that it's broken or the impedance is too high because there's a problem with the insulation or something like that. Anyways, as a general, we prefer bipolar. And so, but sometimes, can you think of any reasons why a surgeon would put unipolar though in? I mean, in bipolar, just so you understand, the lead looks very similar to this, except there's two pods for each lead. So it bifurcates and there's two little pods that have to be sewn onto the heart instead of one. Any thoughts on why a surgeon might put unipolar versus bipolar in, presumably this patient, I think this patient had congenital heart surgery, as we see from the sternal wires, and this is post-operative complete heart block in this patient. Any thoughts on why, and this was neonatal surgery, although the patient at the time of this x-ray is quite a bit older. He's no longer a neonate. Any thoughts, Tarek, on why he might have put in unipolar versus bi? Because I've just given you a whole bunch of reasons why bipolar seems to be better. Surgeons are generally very smart, so why would they choose unipolar?
So, thanks. Probably, so wasn't that feasible if it was done in the neonatal period, like given this the size of the baby?
Yeah, that's usually the reason that a surgeon will give you, is that the patient's heart is so small, there's not a lot of real estate to place the pods on. I have to be honest in saying that is generally, I think, a false argument. I've seen surgeons put bipolar leads on virtually any size patient. In fact, some of you may have seen on one or two occasions, we've had to use this very, very tiny pacemaker called the Microny, which is a St. Jude product. And the device is about the size of a $50. And so in very, very small patients, it's not uncommon that the surgeon will ask for a Microny because they are concerned about the size of the generator and the potential for erosion of the device. And so it's not a great pacemaker, but it is it is great for a patient who's really, really, really tiny and whom you're very worried about that. In that device, the device requires a bipolar lead in order for it to be effective. So in other words, in the very smallest patients who are requiring this tiny little device, the St. Jude device, the only way to use it is to put a bipolar lead in, and somehow the surgeon virtually always can get the bipolar lead in. So although I think that the argument a lot of surgeons will make is that the unipolar leads are better in very tiny patients, in reality, the bipolar leads can pretty much be put in anybody. So anyway, it's an interesting case. And this is an interesting case because the patient actually has pacemaker mediated LV dysfunction in this patient and is being considered for a biventricular upgrade. So,
Thank you, Dr. Price.
thank you. Okay, excuse me. So this is a tracing that I think I got off the internet. And the question I have for you is, what is this rhythm? And I think I'm going to ask Dr. Marshall what she thinks.
Good morning.
Good morning. A pretty crappy tracing. That's a bit of an unfair question, but and it's not a very hard question, but I thought, why not?
So just looking at the ventricular rate, it looks to be a little less than 60. And then someone has already taken the luxury of making some dash marks for what I think are P waves. I'm seeing if that is the same, marching out at the same rate. Originally at the beginning, it's not quite, oh, it's about the same rate. But then as you're looking at the top tracing, we're seeing that those dash marks that someone put in for us stop.
The rhythm continues.
Yeah. And then you're seeing a bit of a change in the P wave morphology initially.
This is actually a pretty, it's a little bit of, it's actually not the easiest tracing to interpret. So what would you say about the PR interval in the first couple, in the beat?
Yeah, it looks prolonged if because it's over 200 milliseconds.
Right. And then what's happening in the middle of the screen, like over here? So I
In
think
the middle, it looks like it's,
yeah,
sorry, go ahead.
I'm so sorry. Go ahead.
It looks like it's lengthening, like that last one, but the last one that's dashed is a little bit longer than the ones prior to. And then you're almost seeing it where it's changing on that next, yeah, but where your mouse is. You're not seeing it quite as clearly, where you're almost losing it in the T wave.
I think that second statement is more accurate. Yeah, losing it in the T wave. And yet the RR interval is not really changing very much.
Yeah, it remains consistent.
So normally you might think this is Wenckebach, right? Because the PR is getting longer, but then it just but the QRS never stops beating. So I think what we're looking at here is isosynchronous beating. In other words, I'm not sure there's conduction in this patient. We would need a longer strip. But it doesn't really, in these beats, right, it appears as if there's a relationship between the P and the QRS. But then over here, the QRS continues straight on at the exact same rate as the beginning, or pretty similar to the beginning. And yet the PR is kind of just really long and it never really blocks. So I think that this is it's hard to say with just one, with just a strip
Right.
or two here, but it's either high grade, it's either second degree block
Mhm.
or maybe even third. We would want to see a little longer strip than
Mhm.
this, but it's an interesting tracing. Okay, good job. Thank you. All right.
Thank you.
So this is a pacemaker check, and this is the electrogram. I don't know. Do you see the? Oh, there we go. That's better. Okay. So this is the electrogram on the pacemaker check, and I have done this is an atrial electrogram, and I have measured the P wave, and it is greater than 5.6 millivolts, and the permanent programming is 0.7 millivolts. So the question is, based on this, is this programmed right, do you think? Why don't we ask Sergey, what do you think?
Good morning. So if the measured P wave amplitude is more than 5.6, and our sensitivity is set up at 0.7, I wonder if the sensitivity should be maybe a little bit higher.
By that, you mean less sensitive, is that right?
Right. The absolute number to be higher to make it less sensitive.
Just remind everybody that a higher number makes it less sensitive. Yes. Why do you think that? Why would you?
Well, my logic is that you obviously want to sense every P wave, right? In order not to deliver pace when it's not needed. But you also do not want to oversense in a way that the pacemaker will consider something that has an amplitude of 0.7 or less, and consider it a P wave, which it might not be. And since we know that all the P waves are above 5.6, I think the sensitivity should be adjusted to be less sensitive.
Yeah. Also, if you look at the electrogram, you see that there's a lot of far field ventricular electrogram here, right? This is the A, and presumably this is the V. So you don't want the device to inadvertently sense this and be inhibited by that. So I would agree with you. It's probably it's probably programmed a little too sensitive. This is a remarkably good P wave. We don't normally see such a great P wave. But as I often say, in my case, sometimes the blind squirrel finds the nut. I guess I got lucky and got a big P wave. Okay. All right. This pacemaker is programmed DDD 70.
Sorry, Dr. Bass, can I ask you a question about the previous question? I forgot. So what is the rule to choose the sensitivity? Let's say,
I mean, generally you would want it to be about, well, the first thing is you want to be sure that it's not oversensing. So whatever you program, you want to always look at what the device, look at the electrogram and look at the marker channels and make sure that it's sensing properly and not oversensing. So there isn't a hard and fast rule, but generally speaking, we would want it to be either half or even a third of the size of the measured P wave. So in somebody with a 5.6, now generally we don't make atrial leads much less sensitive than about 1 to 2 millivolts, unless the P wave is just gigantic, mostly out of fear that we may undersense, maybe. So So in this case, you might set this at like 1.5 or 2 millivolts, and I think that would give you plenty of a safety margin. It's not quite as hard and fast as a threshold programming, where we would always program the output at a minimum of double the threshold, except in very rare circumstances.
Thank you.
Thank you. All right. So this pacemaker is programmed DDD 70 to 190 in a 5-year-old. And this is at interrogation, this is what the amount of sensing and pacing is recorded by the pacemaker with this program. Does this patient need reprogramming? Is there evidence for sinus node dysfunction in this patient? So why don't I ask Maya? What do you think, Maya? Does this patient have sinus node dysfunction based on this? So we'll just go through this. Essentially, the patient is A-sense V-paced 98% of the time, and A-paced V-paced 2% of the time, when programmed 70 to 190 in a 5-year-old.
Okay, so he's A-sensed, V-paced 97 most of the time.
Mm-hmm.
And that, I think,
Yeah.
that sounds appropriate.
Uh-huh.
If you're set to DDD, that is kind of the ideal sensing and pacing if you have appropriate sinus node function. But I guess there is like a small amount in which he's A pacing and V pacing. So there might be, I guess it's hard to know exactly what's going on during that 2% of time, but
When do you think it is that he's A-pace, V-pacing?
probably
This
in
is
the night.
assuming the wires work properly and it's not undersensing or oversensing or stuff like that.
I would probably in the night if he's sleeping or having a sinus bradycardia and it's falling under 70.
Yeah, that's exactly right. So I agree with you 100%. This is a good sign that the pacemaker is probably programmed correctly for a 5-year-old. And we would agree, right? An average heart rate, most 5-year-olds have an average heart rate in the 80s or 90s. So at 70 as a lower rate limit, the device basically is only pacing 2% of the time. And I agree with you, it's probably occurring when the child is sleeping. So when I saw this patient in the office, I made one adjustment to the pacemaker program, which is I lowered the lower rate to 60. Now, I could have set a sleep rate so that, let's say, from 10:30 at night till 6 in the morning, it would set it to 60. But I felt that there was really no reason to ever have the heart rate. It didn't have to always be 70. And even that 2% of the time, I agree with you, maybe the heart rate wanted to be 66 and we were making it 70. And so I thought that by making it 60, maybe I would reduce the pacing 1 to 2%, and that may have a meaningful impact on battery longevity. Probably not a very important one, but as you all have heard me say, we're always when we're seeing patients with pacemakers in the office, we're always trying to figure out ways of prolonging the life of the battery by pacing less or reducing the outputs in some way. And remember, pacing is the biggest battery drain on pacemakers. And so we're always looking to avoid pacing if at all possible. So I set it at 60 just to see if I could get rid of the pacing as minimally as possible. So, okay, very good. I'm sorry we're going to have to cut this short, and I apologize for being 5 minutes late this morning. I'm very sorry. Thanks for joining, and we have more pacemaker stuff next week. So thanks, guys. Have a great day. I'll see you in sign out in a half hour.
Thank you.
Thank you.
Thank you.
Bye-bye now.